Dr. Mohit, you want to share your presentation, or you are okay? So
Yes,
let
sir.
us see.
Yes.
Okay, please.
Should I share the
Dr.
screen?
Yeah, share screen. So to be sure that everything is okay, smooth going.
Just a moment. Just a moment. Yes. Is it my presentation is visible?
Yeah, visible. Okay. You don't have a video, right?
No.
Okay, great. So it's okay. Very clear. You can stop share, please. Okay, Dr. Have, if you want to check, you want to share anything?
Yes, I'll just share my screen.
Okay.
Is it visible?
Yes, visible. Okay. If you have a video, please let us try to check the video if it's working. So to be sure. Okay, great. You can stop. That's it. Okay. Okay, nice. Okay, sorry, if you want, you can do it live, so we can start.
We are live now, sir.
We are on live.
Yes, sir.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Good morning, good afternoon, good evening to all my dear colleagues, wherever you are. Welcome again to MIOM Academy, and welcome to MIOM weekly meeting. And today it's really a pleasure and honor to have a very eminent speaker from east to west of the world, so from everywhere of the world, and between well-known figures in retina. It's a great pleasure to have all of them and to welcome all of them. We will have, as usual, two parts. The first part, it will be a symposium, and it will be a pleasure to have my dear friends, Dr. Mahit. So before we go to Dr. Mahit, just I will introduce our speakers. We will have Dr. George Ruka. He will be the moderators of the second part. And he is also, and we have also Dr. Rajiv Munni. He will join us in a few minutes. It's pleasure and also honor to have today friends of mine, Dr. Gerardo Garcia, Sergio Giantui, and Dr. Hussein Khakan, and Dr. Babhab Sitti. So welcome all of you, and thank you for giving a chance for MIOM Academy and all those that are listening to us to learn from your experience. Before going to Dr. Mohit, we will just have this announcement. Surya, if you can play the.
Hi, I'm Dr. Şengül Özdek. My primary interest is retina with retinal surgery and specifically pediatric retina, including ROP, PFV, fever, codes, Stickler, and the others.
Hello, I am Dr. Sri Ganesh, a well-known ophthalmologist from Bangalore, India. I specialize in cataract, refractive surgery, and presbyopia treatments.
Hi everyone, my name is Dr. George Rocha. I'm from Brazil.
And I'm honored to be invited to speak at the prestigious 5th Middle East Ophthalmology meeting.
I am attending and presenting at the 5th MEOM conference and the 1st Pressmania conference in Dubai.
I'm here to invite you for a very important meeting, the 5th MEOM and the 1st Pressmania meeting that's gonna be held in Dubai next October.
Don't
Okay. So now we can go to Dr. Mohit, please, if you can share your screen and let us start. Thank you.
Is it full screen visible? Is
Yeah,
it full
yes,
screen?
visible, please. Yeah, can go ahead, please. Yes, thank you.
Yes. Just a moment. Good evening. Good evening, everyone. This is Dr. Mohit Jain, and I express my sincere regards and thanks to Miyom for giving me this opportunity, and especially Team Novartis for giving this platform. Today, I'm going to discuss about the role of brolucizumab in the treatment of diabetic macular edema. See, actually, in the treatment of diabetic macular edema, we, as a physician and the patient, both are overwhelmed. We both are having own concern and the issues for the treatment. Actually, patient is having several comorbidities. Most of the patients are having diabetes for several years with coexisting hypertension, neuropathy, nephropathies, and they have to visit several other clinics as well. Repeated frequent anti-VEGF injection is a big challenge for them. Same time, for the physician, it is very difficult to make a decision whether we should start the treatment now or we should do a better systemic control, or if the fluid is not responding, whether we should switch the injection, we continue, even vision is not responding, should we treat the fluid which is visible on the OCT, and keeping the patient on the regular injections, which make the patient quite, overwhelmed and tired with injections. So we have to make some balance between the regularity and the doses of the injection. We have to check the vision as well as we have to look for the OCT criteria like the fluid. So if we see that the number of diabetes patients are increasing day by day, it is very appropriate to say it is a global epidemic. The prevalence of diabetes is around 8% to 13% around the world. In the region where we practice, like the Middle East and the North America, MENA region, around 12.8% population, which is considered as an active adult, including 20 year to 80 year of age, are having diabetes. And the number is about to increase. The prevalence is bound to increase by 15.7% in till 2045. And the global population, and especially population in the MENA region, is also increasing. It translates to around 100% increase in the total number of diabetic patients. So we are going to see more and more patients with the diabetes. In the diabetes, other than the vision, we are our clinical treatment guideline or the treatment decision is based on the OCT, where we find retinal fluid. There are two types of retinal fluid. One is the subretinal fluid, which is generally we see in the later course of the diabetes, and generally these patients are having a poor vision and poor response to the treatment. While intraretinal fluid and intraretinal cyst is again of two types. One is the outer retina, one is in the inner retina. And we observe that the cysts which are in the inner retina, they are having a better response to the anti-VEGF and the corticosteroids. This intraretinal fluid is always associated with the poor vision. The patient who are having a worse vision at the baseline, most often they have a more volume of fluid, whether it is intraretinal or subretinal fluid at the presentation. If the patient is having central involving CSME or CSME and we don't treat, these patients, around 1/3 of the patients are bound to lose 15 letter of vision in the next 3 years. While if we treat, the patient gain the vision. So there is one very interesting outcome which is observed in the RIDE and the RISE trial, where ranibizumab was given for the patient for 3 years. So actually they observed that the patient who are in the sham group, after 24 months, they were offered the intravitreal anti-VEGF injection. So further 1 year, around 36 months, after 12 months of initiation of injection, they observed an improvement in the vision, but vision improvement was suboptimal. The patient who received the treatment since the beginning and were on the regular treatment, they had on an average 13 letter gain, but the patient who started the treatment after 2 years are having an improvement of only 7.5 letter. So the early treatment gives almost 2 times more letter gain comparison to the patient who started treatment late in the study. As we all know that we observe in our day-to-day practice also that if there is a faster fluid resolution or the complete fluid resolution, the vision outcomes are also better that are published and studied in the several studies. So now there is a practical concern that, in our day-to-day practice, we generally consider 2 criteria. One is the vision and one is the OCT. And the patient and we generally more inclined towards the vision criteria, whether we rather than the OCT. But if we observe that, as in the RESTORE study, the criteria for the treatment was the vision stability. So at the end of the study, at the end of 1 year, only 6.8 letters were the improvement. While in protocol I, where they consider the OCT parameters as well, they find that the improvement was around 9 letters. So several international guidelines, including the International Council of Ophthalmology, Royal College of Ophthalmologists, EURETINA, and American Academy of Ophthalmology, they all suggest that we have to look for the OCT, which is, in their word, it is the most useful or the best way to detect and follow up the patient. In certain situation, when we have the vision which is doesn't progress further or stop to improve or improve 6 by 6, but still there are cystic spaces, we should we should try to resolve the fluid as much as possible. So in this preview, we have a new molecule that is the brolucizumab. So brolucizumab actually, if we check, it is a single chain antibody. So actually, antibody is having 2 arms and 1 constant region. But if you compare the entire molecule, antibody molecule, and the brolucizumab, we find that the brolucizumab structure is very small. In simple word, it is just the tip of the antibody where the antibody binds to the antigen. So this variable region is combined with the single chain antibody, and that is also a small fragment of that. So it makes this molecule very tiny if we compare with the other anti-VEGF. So we see that the size or the molecular weight of brolucizumab is 26 kilodalton, while aflibercept is around 100 kilodalton, ranibizumab around 50 kilodalton, and bevacizumab is around 150 kilodalton. So since the molecular weight is less, so the molar concentration in 0.05 ml is higher. It is as high as around 12 to 13 times more than the aflibercept. So we are giving more molecules per injection. And the study shows that the affinity of brolucizumab is quite equal or slightly superior to the aflibercept. So it is having a stronger affinity to the antigen. Since it is a smaller molecule, the study shows that it is having a better penetration in the layers of the retina and retinal pigment epithelium, Bruch's membrane, and choroid. It is having a better penetration, and it penetrates faster. Brolucizumab reaches in the retina after 6 hours, while ranibizumab and aflibercept it takes around somewhere 24 hours. So we have a more concentration of brolucizumab and a faster onset of action. So there are 2 clinical trials that stabilize brolucizumab role in diabetic macular edema. These are the Kestrel and the Kite trial. Kestrel study was was done in South and the North America with some region of Australia, while the Kite was more in the Europe, MENA region, and in Asia region. So in this study, the efficacy and the safety of brolucizumab was studied versus the aflibercept in the diabetic macular edema. The study was done first for the 52 weeks, and there was extended up to the 100 weeks. So this line, the patient's demography and profile was quite similar. In Kestrel trial, there was 3 wings. One was given brolucizumab 3 milligram, which is not commercially available. Other group include brolucizumab 6 milligram, and third include aflibercept 2 milligram. While Kite Kite compared 6 milligram brolucizumab with the aflibercept 2 milligram, and both studies were comparable on the terms of vision, central foveal thickness, and retinal fluid. So the primary endpoint was to check whether BOView was non-inferior to aflibercept or not, and at the end of 52 weeks, find that the improvement in the vision was comparable. The resolution in the subretinal thickness was also comparable between the two groups. The central subfoveal thickness was reduced. That was observed at all study point, and it remained lower up to the 100 weeks. So when we did a sub-analysis at the fixed 32 and 52 pre-specified endpoint, it was observed that the patient who received BOView were having a better central subfoveal thickness, that is subfoveal thickness less than 280 micron in more number of patients than aflibercept. Same way, the intraretinal fluid and the subretinal fluid was lesser observed in the brolucizumab group. Two-step improvement in the diabetic retinopathy severity score was comparable between the two groups. So in this study, it was observed that at the end of 1 year, the BOView requirement was 7 injections, while aflibercept was 9 injections. As BOView was given 6-week interval for loading dose, and 5 injections were given, while aflibercept was given every 4 weeks for 5 injections. So in this study, they observed that if we there are two interesting findings in the this study, that the patient were given a loading dose at 6 weeks, but at the 32 week standpoint, if the patient is having no disease activity, the BOView injection was increased to interval for 12 weeks. So it was observed that the 50% of the patient were having a 12-weekly interval at the end of 1 year, and the same patients were continued till the end of 100 weeks. And at the 18th month standpoint, if there was no disease activity, patients were converted to a 16-week interval. So disease interval increased, and they observed that around 25% of the patients were capped on 16-week interval, 12-week interval. So we can increase the interval from 2 months till the 4 months with the use of BOView. So in this study, they observed that total number of injections were given lesser in cases of BOView rather than aflibercept. If we check the safety profile, though there was a concern about adverse event, especially the intraocular inflammation, namely endophthalmitis or retinal vasculitis or retinal vascular occlusion, which were observed slightly more in cases of Kestrel, but in Kai study, all the adverse events were almost similar. So there is always a discussion about the safety of the BOView, and there are several studies that suggest that though there are concerns, but like if we quote the NICE, that is the National Institute of Health and Care Excellence, it suggests that though there is a concern, but it is very uncommon. And if we see the cost analysis and the disease disability days, we find that it is insignificant. Same way, one study was done in India, that is a Braille study, where BOView was given for ARMD patients, and they find that there was around 94 eyes, and they had around average follow-up of around 5 weeks to 30 weeks, and they find in none of the patient had intraocular inflammation. Same way, I find one study done in Japan, where though it was a retrospective single center observational study, but they did not find any intraocular inflammation, and they observed actually intraocular anterior chamber flare. So antechamber flare is considered as the first sign to get intraocular inflammation, and we can quantitate it, but they didn't find in any patient intraocular flare, in antechamber flare. So I can summarize that significant percentage of the patient with diabetic macular edema are having a fluid, and despite they are trying to get the best treatment, but because of several factors, they are not able to get the regular injections, and they need lesser number of injections, lesser visits to the ophthalmology department. And we have a newer molecule, that is the brolucizumab, which is single chain antibody fragment, which is having a smaller molecule, higher molar concentration per injection, which is having a better penetration in the retina and choroid with a significant effect on the inhibition of anti-VEGF-A. Kestrel and the Chi study suggests that it is not inferior to the aflibercept. Rather, it shows a significant improvement in the anatomical outcome, like resolution of the central subfoveal thickness from baseline. The action started faster, and it was significantly more than the aflibercept group. And more patients of the BOView can be maintained on 12 monthly interval. Around 50% patient maintained 12 weekly interval at the end of 52 weeks. 25% of the patient at the end of 1 year, at the end of 100 weeks, were on 16-week interval. So, and safety profile is also comparable. Here, if the time permits, I will like to share a few of my cases. There is a...
Mohit,
Can I go ahead,
okay.
sir?
Yeah, if you can
5
go
minutes
fast,
more, sir.
2 minutes.
Yes, sir,
2
just
minutes,
5 minutes
please.
more. So actually, I got a confidence for anti-VEGF injection with this patient, where patient had almost PL positive, PR accurate, and having a severe subretinal fibrosis and ARMD. The other eye had the large drusen, just in dry ARMD. The fluid was so much that I'm not able to capture the CMT. It was not even coming on the screen. And after giving first BOView injection, within 3 weeks, there is almost complete resolution of the intraretinal fluid. After second dose, the retina was almost flat, but unfortunately, patient lost the follow-up. He came 3 months after the second injection. The fluid recurred, but even after the third injection, even so much of the gap, fluid completely resolved in 6 weeks. So that gives a wow effect for the patient and the physician as well. That shows a significant amount of resolution of fluid and in terms of vision recovery. And I have never seen this type of response with any of the anti-VEGF, where fluid was so significant and resolved immediately after a single injection. So that build up of confidence, then I started giving the patient injection to diabetic macular edema patients as well. So initially I started giving the patient, giving the injections to the patient who already are on the other treatment. So this was the patient who was given Orzudex previously. And when he presented to me, patient had a severe large cystic spaces and severe CSME. He already had received the 3 injections of Orzudex. We are planning for the 4th. After 4th injection, there was a slight improvement, but not up to the mark. Then I shifted it to the BOView, and to my surprise, there was significant improvement after 1 week. The same way it built up my confidence. Then I gave a patient injection to a patient who had the one eye neovascular glaucoma, and it was in absolute stage, and other eye also had the treatment and received the multiple injection of aflibercept and the laser earlier. So because since she is the one eye, I started with the aflibercept. Then there was, after 1 injection, there was no improvement. I gave the second injection, even that thereafter no improvement. So I shifted it to the BOView, and since this patient was followed for almost more than 2 years, but we never see so much improvement in the macular thickness even after a first injection. So patient is in a follow-up. We have not a long-term study on this patient. I'll update later on once I have further injections this patient. So since then I have given almost 35 to 40 injections. Earlier I was also very skeptical, but now even I have started giving it to the new eyes. Like this patient had a quite large cystic spaces in the retina, and even after first week, there is a complete resolution, almost complete resolution of the fluid. This patient is also had the neurosensory detachment, large cystic spaces, slight component of the VMT as well, having coexisting nephropathy and the neuropathy. I gave the injection. There was a almost resolution of the fluid after first injection, and it maintained after the second injection. Patient had a good vision recovery from 0.4 to 0.7. There's another case, like as the confidence build, we started giving into the cases which are having a lesser fluid and the better vision. This patient had a small cystic space at the fovea, and after the first and second injection, there's a significant improvement. So I will suggest that I will just put my comment that I have not seen any adverse effect, especially the intraocular inflammation after the BUV injection. And I believe it is certainly having some place in our management, and it is something which is very potent. And the draining effect, the resolution of the fluid is something which is amazing. We have never seen this much of the response with even the steroid Ozurdex or other intravitreal anti-VEGF. So I express my sincere thanks, and any questions, it would be my honor.
Thank you very much, Mohit, for this excellent presentation and very good experience on cases presentation. If there is any comment from any of our colleagues here, or if they have any experience by using, I think most of you now use the ViewView. So if there is any comment from anyone, we are ready to hear that. And I'd like also to welcome Dr. Rajiv Munni here. He is joining us already. Thanks, Rajiv, for being with us.
Thank you very much.
Okay. Any question to Mohit about ViewView? Any comment?
Very nice talk, Dr. Mohit. Unfortunately, in Brazil, we are not using, at least we are losing very few ViewView just because of the problem with the vasculitis, and we're not using in large. But no doubt the efficacy of the ViewView is tremendous. We can see in all your case that they dry very well the retina and last longer in the eye compared to Eylea. I don't have no doubts about that. The problem is that we don't have a large experience in Brazil now, just because we are not using in many clinics, many hospitals.
Anyone else want to comment or have an experience? Hussein or Dr. Behab City?
Yes, I think that was a good presentation, Dr. Mohit. And as Dr. Rocha said, now we are moving toward the pattern in which we are increasingly using this drug in India, because I think we've seen the safety profile in Indian eyes is much better than what we had the previous scare of vasculitis, which was there, seen. And so I think now we are moving towards using it from a rescue drug therapy to something in which it can be tried and as a naive treatment as well.
I would just like to add one point that, our all experience with ViewView is after the COVID. It's just my observation that, after the COVID, we get so many of the immune reaction, whether it is like optic neuritis or there's so many of the systemic conditions. So somewhere our experience was slightly biased for the ViewView for intraocular inflammation. Maybe there may be something, who knows. But, as in the several studies done in the India, like the Braille study, which was done in the ARMD, but they find no intraocular inflammation after that. So I think this is a promising drug.
Dr. Rajiv, you have any experience with the
Yes, we started using it initially, and with the changes, with the reports of intraocular inflammation, we greatly reduced, it's used now and then, I would say, by some practitioners, but very rarely. And even the the drug company doesn't seem super interested in the product anymore. Like they're not coming around as much, and they've reduced the promotion of it in Canada. So I'm not using it anymore, but I agree. I mean, I think that, if this was the first anti-VEGF drug, we'd all be using it regardless of the inflammation. And I think in difficult cases, it makes sense. It's, unfortunately for BioView, we have so many options. We have faricimab, we have, Eylea, Lucentis, we have the biosimilars, Avastin, all of that. So, in our system, faricimab is approved, and Eylea is approved, and Lucentis is approved. So, and now even the biosimilars are approved, even though they're not being used yet very much. So when there's so many options, it's easy for physicians perhaps to, just ignore one of them where there's a concern. Do I think that that concern is a little bit overblown? It might be, and I think that, good clinical judgment, examining your patients, making sure that there's no signs of inflammation after the first injection. Those were the types of things I was doing for patients who needed, a lot of treatment every month, or, even some of those RVO cases where you need to inject them every 3 weeks, for example. Those types of cases can certainly benefit. So I think there's a balance between, using it first line and not using it at all. And probably there's a small niche where it would be very worthwhile and effective.
I will give the last comment. Actually, I have an experience with using faricimab when in the beginning with the AMD, and actually on that time it was amazing, and I didn't face or have any experience of any inflammation in the eye. Actually, it was amazing regarding the drying of the macula, and if you are drying the macula, that means the improvement of the vision. In AMD, it was something really wow, because I can say some patients, they are only counting finger and improving to 0.3, 0.4. Some of them, I have many of them like that within just 1 week. I didn't face any medication can do in this way. Yes, there is a concern, but it is, I think it's all, let's say, maybe it's everybody is afraid, or some have some fear to use something that he can vasculate. But vasculitis now, especially in diabetic, according to the study, I'm saying according to the study, it is very, very less and comparable even with Eylea, especially in diabetic, and they are using. Maybe what are the reason, I cannot tell, but most probably we are doing every 6 weeks rather than every 4 weeks when we are using the pralucizumab now in the loading dose. And maybe this is one of the reason. And the other one in diabetic, maybe the response is not similar. Maybe as Dr. Mohit mentioned, the era of the COVID was on the time that we give pralucizumab for AMD. Anyway, we will see what is going to have in the future. We will not go more than that. Thank you, Mohit, and thanks for the panel for these discussions. We can just move, Dr. George. I will leave the floor for you, please.
Hello, everyone. Today, we're going to start this talk about retina detachment. Retina detachment was start to fix the beginning of 20th century with the many great guys. Then we have just to fix the retina with buckles and gas. And after that, we have vitrectomy with Makmer, that the last 20 years we improve a lot with the vitrectomy, with new devices, illumination, the cutter, and many other things. But what we really need? We need vision, need quality of vision. And that we have the master here, Dr. Hajib, that educate all the world about how to pursue a best quality of vision. But now I have a friend that has a flight to catch, and I need to hear what he has to say. Professor Hassan Kagan from Pakistan, all yours.
Thank you, George. Sorry for my hustle, and I will share my one case only here. So, Can you see my screen?
Yes.
So this is just basic of retinal detachment. I just want to convey the message here that you don't need any retinotomy and PFCL for treatment. So you can easily drain the subretinal fluid from primary break, even it is very anterior and even in phakic eye. So this is the case where I'm doing the vitrectomy, and I just want to show you that how I will drain the subretinal fluid from a very anterior supranasal anterior break. So here you can see the primary break is in the supranasal area, and this is macula of fragmentogenous retinal detachment. So that's the basically location of the break. I'm just cutting the vitreous over the break, and here you can see it is there. So so the only thing that I want to convey is that here you can see that I am draining the fluid from the break side area after finishing the vitrectomy. In this case, I stained the vitreous with the triamcinolone, and here you can see my extrusion needle is there over here area, and I am draining the subretinal fluid from the primary anterior break. So you don't need to use any PFCL. Here you can see even the canacort is flushing is going over here. You don't need to use any PFCL or create any retinotomy or retinectomy to drain the subretinal fluid. So even very anterior break, you can just tilt the face of the patient towards that side, and you can do it. So at the end, air fluid exchange was done. So this is just my little humble message. So stop doing retinostomies and just wasting the PFCL in primary fragmentogenous retinal detachment. You can do it. This is the case at the end of the surgery. You can see the laser burns are getting quite nicely at the break area, and you don't need to create any retinotomy or retinectomy or even PFCL to drain it from the in these cases. So that's all from my side. If you have any quick question, I am here. So otherwise, I have to leave. My gates are closing in 2 minutes, so I am in rush.
That's a great video, and I think you make a very valid point that less is more in retinal detachment. We're learning that, and I think that even leaving some fluid and minimal techniques, and you don't have to force the retina attached. So yeah. I think that's very worthwhile.
Because the basic thing is that you have to seal the break and remove the vitreous, and if you have removed the vitreous, seal the break, all the fluid goes away. People are in very hurry in drying the retina. Drying the retina makes it retina angry, and angry retina doesn't show the faces of doctor next day. So that's my point, just humble point. See you again. So I have to catch my flight. Thank you so much for having me. Bye-bye.
Have a good flight.
Thank you.
Anyway,
have a safe trip. Bye-bye.
The idea of less is more is something that you have to keep in mind, because when they don't use PFO, you make less damage in the retina. I mean, less displacement of the retina, less possibility to complication, like you get the PFO underneath the retina. Nobody wants that. But let's listen the talk of the Dr. Haji Muni from Toronto, Canada, that's going to talk about the vision and retina detachment.
Thank you, George, and thank you to all the esteemed panelists here. It's very nice to see you on this Friday afternoon or evening. So today I'm going to talk about optimizing vision in retinal detachment repair. So I want you to see this case. This is a patient 3 months following a vitrectomy for a fragmentogenous retinal detachment. And the patient was seeing 20/25, but they had reduced, they had some complaints. And we would call this a success, right? If we looked at this, we would say the retina is attached, the patient's doing very well, this is a successful outcome. But when we looked more carefully, we found that the patient had significant metamorphopsia and anisoconia. And it turns out that a substantial proportion of patients have these findings following retinal detachment repair. And these symptoms can last even for years. I have one patient who 15 years post-vitrectomy is complaining of anisoconia in that eye. The PIVOT trial was a randomized control trial that compared pneumatic retinopexy to pars plana vitrectomy and demonstrated that ETDRS visual acuity, which is what we strive to maximize, was superior at every time point, including the 1-year endpoint. And you can see that at the 12 months, it was better by 4.9 letters. But what was most interesting was that in the vitrectomy group, there was significantly worse vertical metamorphopsia, both in terms of the severity of the metamorphopsia and what proportion of patients had metamorphopsia. And this was very enlightening because for the first time it showed us that the mechanism we use to reattach the retina may impact outcomes. Before that, it was, well, if the retina is attached, it's attached, that's it. But now we have some evidence. And what we did is we send the OCTs from the PIVOT trial to the Doheny Image Reading Center, and they took 2 masked graders and assessed the images for ellipsoid zone and ELM discontinuity. And we found that the risk of these photoreceptor abnormalities was significantly greater with vitrectomy compared to pneumatic. Again, pointing to the fact that the method that we use to attach the retina impacts the recovery of the retina following retinal detachment repair. So we should pay attention to how we're attaching the retina. This patient now, let's go back to him, he was 3 months, 2025, but he has significant vertical and horizontal metamorphopsia and severe anisoconia, where everything is smaller. And if we took a fundus autofluorescence image, we see these hyper autofluorescent lines indicating the location of the retinal vessel before the retinal detachment compared to where it is now. And we see that the vessel has shifted. Even though the vision is 20/25, the retina is in the wrong place. And so as a comparison, this patient following pneumatic retinopexy was 20/20 following fovea off detachment and did not have any of these symptoms. And we can see on the fundus autofluorescence that we do not see those hyper autofluorescent lines indicating that the retina has come to a more natural position. But this is just one case. So we carried out a multi-center study where we compared the risk of displacement between pneumatic and vitrectomy. And it was very well known that in about 40 to 50% of cases, you see this with vitrectomy. This was shown by the British, the Italians, the Japanese. All series point to about this rate of around 40%. But what was new was that it was very low following pneumatic retinopexy, 7%. So again, this is the second thing that points to the fact that the outcome varies based on the technique. Okay, so that's another key message. So here's another example showing these hyper autofluorescent lines. You see the whole retina has been shifted inferiorly, indicating that we can do something to improve our outcomes. We then carried out a prospective study, again, looking at the same thing, but only in fovea off detachments. And again, we confirmed with vitrectomy about 50% of patients had this displacement versus 14% in the pneumatic group. This was higher than the 7% from the previous study because this only included MAC off cases, whereas the other one had MAC on and MAC off. And what we did was in this trial, we also measured anisoconia. Retinal displacement is a stretching of the retina. So when you stretch the retina, you stretch the cone mosaic and objects appear smaller and pinched in. That's why if you ask your patient, they'll say, "Doctor, your head looks smaller, your body's fine, and it's pinched in the middle." And this is a classic symptom related to the stretching of the retina. So that was worse in the vitrectomy group compared to pneumatic, and also worse in displaced cases compared to non-displaced cases. Now, we then carried out another study with our colleagues at Shankar Nichalia in India, where we compared buccal vit versus buccal. And again, we found similar concept that the risk of displacement was significantly less with primary buccal and higher with vitrectomy. And surprisingly, about 15 to 17% in the buccal group had displacement. Now, why did they have displacement? Well, this is a classic buccal with no drainage showing no retinal displacement. And on the right side, you see after vit buccal, you have significant displacement. But what we found was that patients who had drainage did get displacement in the buccal group. And again, that was because your forcing fluid. We'll talk about why that happens, but you're moving fluid. Anytime you try to move fluid, whether that's by external drainage or in vitrectomy, at the end of the procedure, when you have a large gas bubble, that pushes fluid to the periphery when the patient lifts their head after surgery. That movement of fluid stretches the retina, and that's what causes retinal displacement. Now, how can I prove this to you? Take this case. This was an example of subretinal fluid, a retinal detachment. And while we were trying to figure out what is the cause of this retinal displacement, we injected perfluorocarbon liquid. And the idea was, let's leave the perfluorocarbon liquid in the eye. So we will use a short-term PFCL tamponade. We will not go to air. I thought that if we don't go to air, then the gas would not push the fluid at the end of the surgery, the residual fluid, and that you won't get the stretching of the retina. So here you can see the PFCL is going in very, very slowly, and all the fluid was draining infratemporally, which is where the break was. Now, you would think that if my theory was correct, you would have no retinal displacement, but what we got was the worst retinal displacement we've ever had. And that's because it clicked that the cause of displacement, it doesn't matter what you're doing, but if you're moving fluid, if you're forcing fluid to move from point A to point B, the retina, which is a thin elastic membrane, is going to stretch in that same direction. So you should never try to force fluid to move in a certain direction. And this made sense why buckles with drainage cause displacement. You're forcing fluid to move and then sticking the retina down. Here with the PFCL, we force the fluid to move and then stick the retina down. With a vitrectomy, we have a large gas bubble. It displaces the fluid, and then the bubble holds the retina in position. So it stays in that stretched position. So how do we assess the integrity of retinal reattachment? What do we do? Well, we want to use fundus autofluorescence imaging. We can detect this at 3 months to show this movement of subretinal fluid under the thin elastic retina. And it's this movement of retina that causes the hyper autofluorescent lines that you see on the fundus autofluorescence imaging. And this is causing a stretch of the retina. And this stretch of the retina is what leads to objects being smaller or pinched in. Now, this is another case of a supratemporal retinal detachment with a supratemporal break. You can see that in panel B, after a vitrectomy, maybe some faint hyperautofluorescent lines. But look at panel D. What was unique in this case is we had the FAF from before the patient ever had a detachment. And we overlaid these two FAFs, and we can see that the nasal vessels are perfectly aligned. But look at the temporal vessels. They're completely displaced and duplicated, indicating that the entire macular region, the whole temporal retina, has been shifted from its original position. Now, some may say, well, I do FAF and I do this technique or that technique and I don't see retinal displacement. It's not common in my practice. So I'm going to show you examples where the FAF is negative. Here you would not be confident to say there's retinal displacement, but we've developed a technique called homography where you can take OCT images, en-face infrared images from before and after the detachment. You need OCT before they ever had a detachment. And when you overlay these using RPE and choroidal landmarks, we can label the vessels different colors and we can see that the retina has shifted even when the fundus autofluorescence is negative. Here's another example on the left. The FAF does not show significant displacement, but the homography of the OCT shows significant displacement. Another example, you would not be confident to say retinal displacement, but when you look at the homography, it's shifted. And as it turns out, 100% of vitrectomy cases have this displacement. Anytime we have a pre-RD OCT and a post-operative OCT and you overlay them, you're always seeing a stretch of the retina, a shifting of the retina. I'm now going to switch into outer retinal folds. This is another thing we compared in the PIVOT trial. And here you can see a significant presence of outer retinal folds on the en-face OCT. It's beautiful en-face OCT to see these folds. When you get outer retinal folds, your visual acuity is going to be worse than if you don't get these outer retinal folds. And this also happens more in vitrectomy. Another very interesting imaging biomarker is using en-face OCT. And with en-face OCT, you can see these areas of hyporeflectivity indicating damage to the photoreceptors that gradually improves, even up to 7 years later in our prospective studies. We also use en-face OCT to monitor residual subretinal fluid blebs, which always resolve over time. we've recently characterized how retinal detachment is staged and how the retina actually reattaches, which is something we haven't been able to look at until very recently. We see that the patient has subretinal fluid redistribution, and then you see contact and reduction of the cystoid edema and corrugations, then contact and then deturgescence of the photoreceptors, and then you get a recovery of the outer retinal band. So when we talk about how the retina attaches in surgery, but how does the retina attach in a microstructural manner? We've now been able to study using pneumatic retinopexy as a model, and we've been able to understand why sometimes you get these outer retinal folds. So let's look at some examples. This is a patient who underwent pneumatic retinopexy, and you can see initially there's a redistribution. Look at the CME and the corrugations. In stage 2, they go away, and then you get contact in stage 3, and then look at the outer retinal bands. It deturgesces, and then you get a recovery in a very predictable manner from the ELM to the ellipsoid zone to the interdigitation zone. And then you get a reconstitution of the foveal bulge. Now, what happens if you attach the retina too quickly? Well, let's look at this case of a supratemporal and look at the corrugation here forming an outer retinal fold on the left side. In other words, if you attach the retina very quickly, the retina will not have time for those corrugations to resolve, and they'll attach in a corrugated manner, as opposed to if in pneumatic retinopexy, we allow the retina and the fovea to attach very slowly. Look at how these corrugations all smoothen out before the retina attaches. So you can imagine in vitrectomy, if you're forcing the retina down, in other words, there's not enough time in stage 2 of reattachment, then you're going to get more outer retinal folds, and we know this is associated with worse visual acuity. This is a patient who had pneumatic retinopexy. You can see the large dialysis, and the retina reattached, but there was this residual subfoveal fluid bleb. Now, we see this with any non-drainage procedure, including things like scleral buccal non-drainage. And here you can see the en face OCT over time, just like puddles drying up in the sun. You can see that they are resolving. So I just want to do a time check, George. How many minutes do I have now? Do you know approximately? I don't want to go over.
I think you should finish in the next 3 minutes.
3 minutes? Okay. So I'm just going to talk a few more minutes about, just let me know 3 minutes. So this is a patient who has corrugations. You can see the corrugations in the outer retina, and we've recently used ultra wide field SSOCT, and we've characterized the outer retinal changes that occur with progressive detachment. And if you have a detachment, the longer it's detached, it's going to undergo these structural changes. And we've basically categorized that initially you get a separation, but you can still see the outer retinal bands. Then you get a hydration, and that hydration causes a lateral expansion, which causes these corrugations. Then you get a thickening that you lose definition of the corrugations, and then you get patchy and complete loss of the photoreceptors. And the longer the duration of detachment, the worse the visual acuity outcomes are. And these are 3 patients who all said that they were detached for 1 day, but we can clearly see that the patient on the bottom was more chronic. And we think that we can use OCT to help guide our treatment decisions. In other words, don't do every macula off detachment in a week, but pick the ones that can wait and look at the OCTs where you still have an intact bacillary layer, intact photoreceptor layer, and those should be done more acutely. Now, what happens in the fovea? Within the fovea, we have something called the Mueller cell cone and the central foveal bouquet of cones, and we've recently described this phenomenon called bacillary layer detachment. And this is basically what happens in the fovea as a result of this increased hydration. And you can basically see, I won't go into all the details, but you basically get a eventual breakdown of this bacillary layer detachment, forming what we call a ballad lamellar hole, which leads to a full thickness macular hole. So we've recently described this pathophysiology. So I'll wrap up in saying that there's been this historical focus on primary reattachment rates. And I think that we have to start thinking about functional outcomes, because in this era with imaging, we are learning so much more about how, from a microstructural perspective, the retina attaches. And anatomic reattachment is just the base of the pyramid. It's not enough. We need to have integrity of the attachment and functional outcomes. And as George very eloquently mentioned, we had all these heroes in retina who taught us how to attach the retina. But we have to take home the message that anatomic attachment is no longer equal to success. And remember this picture where your whole macula is shifted, and ask yourself if you would be happy with this outcome. I'm sure that you wouldn't. And I think that tells us that we can find better ways to attach the retina. And so I'd like to end there and thank you for this opportunity. And if there's time for comments or questions, I'm happy to answer them.
Wow, what a magnificent talk. Rajiv, you are spreading a new era of retina repair. We have to change our mind, change that it's not only reattach the retina. We need more than that. We need to think what the best technique to reattach the retina and also to make the vision better. And we are looking for the Retina Detachment Repair 2020. And with no anisocony, metamorphopsy, and all the bad vision we used to have. But in the old times, like nowadays, universally, people just think, okay, the retina is attached, my job is done. And then the patient complain, oh, I don't see well, the vision is distorts. But we say, okay, it's normal. Every retina repairs, you're gonna get that. But now we are doing in a different way. And if I understood well your talk, we have two big brains. One is time. We need to repair fast. Another is what the best technique to not displace the retina. And then we are doing a lot of vitrectomy using gas. And does technique change the results? If you do less, you're going to have much better vision than if you do a lot. If you put a buccal, do vitrectomy, active drainage, and also put gas and put PFO, all this, we're going to squeeze the retina. And this stretch of the retina going to change the position and maybe kill some photoreceptor. But anyway, my only question is, the vitreous substitute, what data you have between gas, oil, or nothing? What's the best vitreous substitute?
Yes, so the displacement that's related to the gas is related to the buoyant force of the gas. So the gas bubble has a specific gravity that's very different than water, and therefore it applies a buoyant force to the retina, which is substantial. We know this, that when you put even a small gas bubble, it rapidly displaces fluid away from it. And so we have a lot of data from our mechanical models, also clinical data, that suggests that it's the bubble, the size of the bubble, and the bigger the bubble you have, the more force is applied. So to give you an idea, when in pneumatics, when we use 0.6 SF6 versus a full gas fill, in the pneumatic scenario with that initial 0.6 bubble, it has only 3% of the buoyant force is applied to the retina compared to the full gas fill that you have with vitrectomy. Now, silicone oil, because its specific gravity is very similar to water, does not apply a buoyant force to the retina to the same extent. And so silicone oil, or a novel vitreous substitute, which likely will be coming down the road, where you have a specific gravity closer to water, there you can minimize the risk of displacement. Now, of course, we generally don't use silicone oil primarily because there's other issues with silicone oil. So it's not ideal for many reasons. But I think that as technology evolves, we will have better vitreous substitutes that are more like hyaluronic acid type of substitutes that are that will dissolve, that will be clear, and that may apply less buoyant force. And I just want to comment on your comment. I'm very pro-pneumatic, but I know a lot of people are pro-buccal or do a lot of vitrectomy. And I think that the concepts that I've talked about today do not just apply to pneumatic retinopexy or to one procedure, but really I'm rethinking how I do each of those procedures. And I'll give you an example. Yesterday, I had a patient with a total detachment, and no visible break. So I didn't do a pneumatic because I had no idea where the break was. I went in, I did the vitrectomy. I saw a single superior break at 11 o'clock. So at that point, I knew that I did not need to drain. I did not need to do an air fluid exchange. I did not need to put a large gas bubble. So I simply closed the eye. I injected a 0.6 gas bubble, and I did the same positioning I do with pneumatic retinopexy. And today the patient came and was 90% attached. So, I'm changing how I think about vitrectomy, also how I think about buccal. I may decide to drain a lot less than I used to, for example, with primary buccal. So I think these are concepts. And now that we have imaging, we have to rethink everything, the positioning, the tamponade, the drainage method, all of these things from a microstructural perspective, because ultimately we want to restore the integrity of the photoreceptors and allow the patient to see better.
Great. Any questions from the panel? Yes, has Gerard, please.
Yeah, Rajiv, the work that you have done in this regard is amazing. Congratulations. This was like a keynote lecture in 10 minutes. So thank you for giving us that and making us understand what is really happening, as you said, with objective measures and not only retinal reattachment rates. Have you looked up if the use of PFO really worsens things? Because that would be my impression. You are attaching the retina in a fixed place, and then regardless of what tamponade you use, you get more displacement. But I understood from your talk that the gas was kind of the same. So is there one that has more weight than the other?
So are you talking about intraoperative use of PFCL or use as a tamponade?
Intraoperative, yeah.
Okay, so if you use it intraoperatively, it'll stretch the retina in the direction of the drainage. But then what happens is we take out the PFCL, so it'll recoil back. So you need two things to cause displacement. You have to move fluid, and then you have to hold the retina in that stretched position. So the PFCL doesn't help, it doesn't hurt really specifically in terms of displacement. Then what happens is now you've done your air fluid exchange, you put a full gas fill, and some residual fluid always comes posteriorly. Then the patient lifts their head to go to the washroom or to have tea after surgery, and then immediately that fluid gets shifted down below and the retina gets stretched. But I will say that displacement is not the only anatomic biomarker that we're interested in. So we recently published a comparison, and this goes to Hussein's nice talk, that drainage from the break versus posterior retinotomy versus PFCL. The PFCL had the worst visual acuity, had the most disruption of the photoreceptor layer compared to the drainage from the break or posterior retinotomy. Posterior retinotomy had a lot of ERM formation. So drainage from the break did the best. And these are all uncomplicated detachments. The reattachment rates were similar in all three groups, the similar baseline characteristics, but the PFCL group did the worst. So, I know Stanley Chang is not in favor of my opinion, but I don't believe that PFCL is a good adjunct for routine retinal detachments. Of course, it's changed our life for GRTs and PVR and retinectomies and all of that. And it's an essential tool in our toolbox. And sometimes we have to use it, but would I use it for any macula off detachment like the one Hussein showed? No, I don't think that there's any benefit, and potentially there's harm.
Great. Sethi, Dr. Sethi.
Yes, I think a very lovely presentation by Dr. Rajiv. He's just put everything in a nutshell and explained to us a different way of looking at retinal detachments. My question is, do you think from henceforth, with the knowledge we're gaining now, limited vitrectomy with some amount of fluid at the posterior pole is the way forward if you're going to be doing vitrectomy, to let that get absorbed on its own, take its own time, and avoid all these complications?
Yeah, 100%. So, I understand that, we've all trained differently. And so there's going to be a lot of people that are trained in the vitrectomy era that's what they're comfortable with. They like wide field viewing. There's definitely advantages to examining under scleral depression in the operating room, identifying every break and treating it. What are the two potentially harmful parts of vitrectomy? Two things: the drainage and the large gas bubbles. So if you can think about how you can modify your techniques so you can minimize the need to drain and you can minimize the size of the tamponade. If you do a vitrectomy and there's a single break at 12 o'clock, we have very good evidence that pneumatics work great in that scenario. So why do you need to do a 95% gas fill in that case? It's unnecessary and it's causing harm. So, and similarly, if you have some residual posterior fluid with a small gas bubble, that fluid always goes away. The RP pump is the best thing we have to absorb fluid. It's better than anything we can do. So why should I try to dry it out and see it flat like a pancake in the operating room? It doesn't make sense. So these are the two concepts I would say that you can take away. And even being pro vitrectomy, you can think about how to change your approach. And I think that the combination is key though. If you leave a lot of fluid but then put a big gas bubble, it's going to displace the fluid as well. If you force the retina attached to minimize the fluid and displacement because you don't want that fluid to get shifted, then you're going to get other things like outer retinal folds. So it's the two things together. Don't drain too much and don't use large gas fills, and try to figure out how you can, close the break without that. And people are talking about supine positioning and, so there's so many different ways and things that will come around, that there's retinal sealants. There's going to be a lot of really exciting evolutions in retinal detachment repair.
Good. And now for the sake of the time, let's start to discuss the case. I think the first one is going to be Dr. Gerard Garcia from Mexico, a professor and a very good friend. Please share your screen and
George,
kick
I
off.
think there is questions from audience, 4 questions.
Oh,
You want to take it now or later on?
I can't see the questions. Oh.
Yeah, there is 5 questions. If you want, I can read
Oh,
them.
Yeah, for sure.
But why don't we do that? Why don't we do them at the end? I don't want to take away from the other presentations. So why don't we? I'm happy. Why don't we go through and then we can address? Is that good?
Yeah, let's go ahead with the presentation. After that, we can take the questions. Please.
Okay. Can you see my screen?
Yes, for sure.
Okay, so I think Rajiv is going to like this case. So this was a 57-year-old male. He was already scheduled to have cataract surgery in the left eye, but while he was waiting for it, he started complaining of a progressive scotoma that reached the central visual field in the left eye. The visual acuity was 20/40 with metamorphopsia. He had significant cortical cataract, and he had a temporal retinal detachment that just reached the fovea with a superior lesion. So he underwent the phaco, IOL implantation, pars plana vitrectomy, endodrainage, endophotocoagulation, SF6 gas tamponade, and no PFO was used. And immediately after surgery, and we can discuss about this, the patient was positioned over the left side and then sitting upright after leaving the operating theater. After gas reabsorbed, a patient had a BCVA of 20/25 and had some metamorphopsia. So here is the fundus image, and you can see here there is a line, demarcation line that shows where the retina was detached in the temporal part, and it was involving the fovea. And it can be seen more clearly here in the infrared image. I don't know if you can see my pointer options. Okay, visible. You can see my pointer.
Yes, we can see.
Okay, yeah. So you can see the line there, and in OCT we had some subfoveal fluid, as you can see there, and this is the several cuts, superior and inferior to the fovea, and we can see that there is a very small but a significant fold that's going through the fovea. So I want to know what were your thoughts and what should we do in this case?
So this looks to me like a residual subfoveal fluid bleb. I see the demarcation line of where the retina was detached, and then I see some residual subfoveal fluid. So my recommendation would be to just observe this. I wouldn't do anything. I think that it will naturally reabsorb over time.
Totally agree, and that is the message that I wanted to convey in this case, that these ones you just have to sit and wait out. And 3 months later, visual acuity was 20/20. As you can see, the that string of small subretinal fluid blebs is already disappearing. And even though it persists in some parts, the fovea is already attached with some ellipsoid zone alterations there, but the patient was 20 happy and 20/20 as well. So the thing is how to avoid retinal folds, because this was a minor problem, but sometimes you can have this, and this is one of my, when Rajiv is talking about leaving subretinal fluid, and I do it as well, but I am always concerned that something like this will happen. And so one of the tips that for me is important in these cases, and this was published in Retinal Physician by Paul Hahn from teachings from Dr. Cynthia Toth, is that the cases that end up with folds like this usually are superior retinal detachments that involve the fovea or near the fovea. And when you place the gas bubble, as Rajiv said, and you are immobilizing the fluid that's exactly passing through the macula, and if you don't position properly, you will get a very big fold like the one in the picture before. So one good tip is to place patients lying on their temporal side immediately after surgery. So fluid is displaced to the temporal side. You have the optic nerve immobilizing the retina in the nasal part, so you don't get these kind of folds. And that is all.
That's a very interesting presentation, and I think there's actually some very interesting thoughts about outer retinal, full thickness folds. And the one thing we have to remember is that this is an iatrogenic phenomenon. It's related to the drainage and the movement of fluid. And very interestingly, in pneumatic retinopexy, it's impossible to get those folds because you're never draining fluid. You're never moving fluid from anterior to posterior like that at the end of surgery. So what are some of your intraoperative tips? I mean, in these superior detachments, they do well with other techniques, but let's say you're doing a vitrectomy. How are you, other than the positioning, what else are you doing to kind of minimize?
So one important thing for me is obviously drain through the break, as you said, and as Hussein showed. I think that is very important. Another thing is to drain the fluid before starting the air infusion, because sometimes what happens is if you start the air infusion at the same time that you start the drainage, the bubble will start coming down and eventually it will block the break. So you will be left with a lot of subretinal fluid that you won't be able to access unless you do a posterior retinotomy. So that is one of the main tips that I would give in this regard. Besides the temporal positioning immediately post-op. I don't like to use PFO. I think they are more prone to risks than what they're really achieving. But I know that people use them in every case of retinal detachment.
Yeah, today I just had a case also of a subfoveal PFCL that we had to create a bleb and remove. Definitely this was a trauma case and we had to use it, but it's not always without risk, and I agree it's not necessary in most cases. I think that your comment about drainage is really critical. In fact, whenever I'm operating with a fellow, I always tell them, start the cutter, and before you switch to air, start that drainage process. So your retinotomy is patent, the fluid's moving out, and you're actually exchanging subretinal fluid for air rather than the intravitreal fluid for the air. And so, you get a better, you just get a better physiological status in terms of the mechanics of attaching the retina in that way. So I think that that's a good point to avoid that large bleb of fluid posteriorly, and then you're going to put in a full gas fill, and it forces that fluid to form a fold. So that. And what about in terms of dealing with the fold? How, if you have a fold, when do you go back in for surgery, and what's your approach for that?
I think a fold like the one I showed, not the case itself, but the one in the image, you definitely have to deal with it surgically. So it has to be a significant full thickness fold that is causing a disturbance in vision for the patient, and you have to go in, redetach the retina. So you have to inject with a subretinal needle fluid. Sometimes you have the risk of the fluid coming out through the fovea, so that is one of the complications that can be expected with this technique. Try not to inject. Some people trying to inject directly into the fold. I think that would have a higher chance of coming out through the fovea. So maybe injecting at 4 points around the fold, so you can create 4 different blebs that are confluent in the fold, is the best way to deal with this, and then straighten it out. Leave gas and you know, let it settle.
Yes, a great case. So many good thoughts in this case you bring to us. The first thing is, if you remember, before OCT, all the papers from the retina reattachment, we have to wait 6 months before to say is a final vision. And then it's because we didn't know that it has some fluid that's going to take time to come out of the fovea. And sometimes takes more time than 6 months. I saw a case that takes almost 1 year to reabsorb all the fluid, but we have just to wait. Some people use Diamox. I really don't know if Diamox is going to help or not. Maybe yes, maybe no. But I think time is the only thing. If you have very healthy RPE, gonna pumps more fast than a high myopic patient that has very few RPE working. But another thing is the vitrectomy and the drainage. We agree here that we should start drainage before fluid exchange. That makes more suitable the process, and not push all the fluid from the macular and the position of the gas. Another thing I'm just using more is not to do a complete air fluid exchange. I don't need to remove all the fluid from the retina. I just need to have dry the hole and laser, and let the fluid go by RPE pump. And I don't need a big bubble. I just maybe more than a half, but don't need complete fluid exchange. But just my thought about that.
One of the drawbacks of doing a completer fluid exchange is also that you always have some residual subretinal fluid, you know, lying around. Yeah. And if you do that, then the air is going to push that fluid to the posterior pole because of the way the patient is positioned during surgery. So I think leaving a puddle of fluid is always a good thing.
I agree. Okay, let's move for the next case, because so many good things and have so many good questions for the end. I think going to be a great discussion. And next presenter going to be Dr. Sethi. Dr. Sethi is all yours. Share your screen and go ahead.
Yes, thank you very much. And I'll be presenting a case scenario, I think, which is the only thing that pneumatic may not be suitable for. So, or maybe
not for Dr. Mooney. I'm sure he will go for a pneumatic.
In my mind, yes.
Yeah.
Okay. So a 22-year-old young male came with left eye vision loss since a week, and he had a superior GRT with a retinal detachment and a cortical cataract. So after dealing with the cataract and putting a suture of the tunnel, I started with a 23-gauge vitrectomy, and this was a superior 180-degree, almost a 180-degree giant retinal tear. And along with that, while I was doing the core vitrectomy, there was already a posterior vitreous detachment in place. So I continued with the vitrectomy, but what happened is, while doing it, the retina became bullous. So now the focus was on the anterior flaps of the GRT, and they were quite sticky in this young male, sorry. And I was trying to do my best to shave off the vitreous there and clean off the anterior flap. And also in the same process, you know, sometimes what happens is when you focus somewhere else, you kind of lose focus on your port area, which is a very important basic thing to just clear off the vitreous there. So some amount of retinal vitreous was just getting stuck in the port area. So because I was using a chandelier, I was careful enough to just remove that retinal tissue, push it back, and carefully push in PFCL slowly and steadily, not to create multiple bubbles, just keep in the same bubble and slowly and steadily inject to push down the giant tear as well as the detachment. So now when I was sure that I was behind the posterior edge of the break, I continued my peripheral vitrectomy and slowly just clearing off the peripheral vitreous and with the help of indentation to prevent any retinal mobility and this clock arbor wise clearing off the vitreous base excision, whatever I could do clearly, because it's especially now pseudo-phakic, so I was much more comfortable also. And in the whole process, I have also created a small iatrogenic break inferiorly. So there's a small PFCL bubble. I didn't want this to go subretinal, so I had to just clear that off. It's very important to do that in case there's a small bubble that's separately present. And after clearing off and doing a peripheral vitrectomy, you can see now the retina looks a bit better. But now coming back to the main issue that I had was that this anterior flap, sometimes it's easy to remove, sometimes it's difficult. This rolled edge of the posterior flap was a little bit of, it was difficult to flatten out. So I just shaved off this little bit of PVR that was forming at the edge of the posterior flap of the GRT, making sure otherwise there was higher chances that this could later on cause PVR and detachment. So very important, just clear off this area around the posterior edge of the GRT, and also wherever you found traction in the anterior areas, just be very careful to shave off the anterior edge of the flap as well. But the problem I was having is this anterior edge was in some parts very sticky. It was stuck onto the peripheral. You can see here, I was trying to just peel it off. And I was successful in some areas, and some places I was not very successful. So I just left it as of now. By this time, the corneal edema had slightly set in. The cornea was slightly hazy due to my maneuvers. So I made sure I was able to see the GRT extend and did a diathermy around that area before the fluid air exchange comes through. So after this, I increased the PFCL level by just tilting the globe inferiorly and increasing my PFCL injection. I tried to milk out the fluid through the GRT area as much as possible to prevent any cuff of fluid being there in the inferior area or in the nasal part of the retina, and making sure I do my vitrectomy after increasing the PFCL level. So the area of the anterior flap, which I was not able to peel off, I made sure I did laser there so that sticks on. Otherwise, it's sometimes detrimental to leave that residual stump of anterior flap that can sometimes curl up and even attach to the ciliary body process, and later on maybe cause hypertony and other damaging consequences which may lead to long-term issues with the patient. So making sure I'm thorough with this laser all around the residual anterior flap floor fold and all across the giant retinal tear. And now going to I normally do a PFCL air exchange. So making sure slowly and gradually with low pressure of air, just being at the margin all across and trying to dry up the tear and making sure that the whole process takes some time before I shift on posterior pull. And after that, finally injecting silicone oil. So the patient is doing well now post-op, but a lot of things I could have done maybe differently. So I just wanted the suggestion of the panel and a discussion here. What could have been a better approach, or how would you manage it differently? Thank you.
Thank you. Giant tears is all a value challenge for everyone. I think you did very good. And one thing that's it's not easy is the fluid air exchange, or if you have slippage, you have to go directly for perfluorocarbon and oil exchange. But in my practice, I try as much as I can air fluid exchange, not oil. And what's the good tricks for exchange, not slippage? What do you think?
Yes.
I mean, I think that the speed at which as Vaibhav very nicely showed, that he really took time to drain. I think that's really one of the critical moments if you're going to use gas. Sorry, Vaibhav, you were going to say.
Yes. So, Dr. Raji, would it be a wiser decision to use a gas in this patient, or would you have still stuck to oil? Which scenarios would you be using a gas in a GRT?
I mean, my general preference is gas, but I think that if you're having trouble with slippage, and I try an air fluid exchange and it slips, I might consider refilling with PFCL and using silicone oil, a direct PFCL oil exchange. In some very nasty GRTs, I'll actually leave the PFCL in, and I know I've talked about how that causes stretching, but in some cases it's so bad that you don't care about that. You just want the retina to be attached in some location. And so, I think that leaving the PFCL in for a week or two and then removing it is also an option. So I think you have three options. My preference would be gas, and then would be the PFCL or oil second.
I agree completely. I use sometimes PFCL, but only for 1 week. I didn't have any complications, side effects, anything. But sometimes if you try many times and you can't put the retina in the right position, PFO can help a lot. But have to take it out before 15 days, I think. I used 1 week and never had any side effects for that. And the other stuff that's have to take care is the anterior flap. This anterior flap can fibrotic and displace the ciliary body. I think you did good. You remove all the anterior flap, and the young people has to take care about that, because this flap can cause a lot of problem in the future. But anyway, very good case, and it's very challenging because you have a high level of the scars in the future, PVR, and then maybe you have to go back and reoperate. It's not done only when you finish the giant tears. Maybe you can come again and again, because we have a large area of RPE desnude, and then we can have a lot of problem. But anyway, for the sake of time, I think we should move ahead. Thank you so much, Dr. Senti. Great case, great surgery. And now we have Dr. Sergio from Brazil. Sergio Pimentel is the head of department of the USP University, one of the largest ophthalmology department in Brazil, located in São Paulo. Please, Dr. Pimentel, go ahead.
Okay. Hey, Jorge. I would want to share with you a case of a different complication. There was a 55-year-old white male with a paracentral scotoma in the nasal portion of the visual field shortly after the primary pars plana vitrectomy for retinal detachment. He notes the lesion, the spot, even with the gas tamponade, right? During the gas tamponade. The surgical technique was first pars plana vitrectomy, posterior hyaloid removal, retinectomy for anal drainage, and C3F8. The best correct visual acuity was 20/40. I saw the patient 1 month after the procedure, and that was the retinography, the color fundus. That was the fundus autofluorescence. With the we can see the macula was without problems, right? We cannot see any damage here in the color fundus, not in the autofluorescence, right? And we see the retinotomy above the arcades. OCTA was, for me, was normal, superficial and deep capillary plexus and the choriocapillaris. That's the visual field with the scotoma paracentral, almost going to the fovea, right? Thank you. And that's the microperimetry. And the patient described it very well, that lesion, right? That was the OCT with inner retina lesion, temporal to the fovea, right? And that was the follow-up after 6 months, obviously without improvement, right? And the complaining was maintained. So that's the summary. And I'm asking you to, if you have seen this before, I will finish after reviewing this case. And have you seen this before? What's caused it? And how can we prevent that?
So a couple of comments. Now, there in the OCT, in the structural OCT, there is some atrophy of the inner retinal layers. So that would kind of point to me to some ischemic damage. I have seen this not in surgery for retinal detachment, but some for epiretinal membrane in one case that developed ischemia of the deep plexus after surgery. The real cause is uncertain, but it does happen. Now, another, not with this particular pattern, but way back when we used 20 gauge vitrectomy, there was always this issue when you did a fluid exchange that the jet of air was somehow damaging the retina, and this was atoned a little bit, humidifying the air. And another thing that you have to think in this case is, did you do any ILM peel or something in this regard?
No, it was not done by me, for a colleague. And I saw the patient 1 month after, and there was no epiretinal membrane peeling or IOM peeling. That's a good question. There was not.
So another thing that to consider, not with this OCT, because I think the problem is in the inner layers, but phototoxicity has to also be in your differential diagnosis. Those are the three things that I will consider.
Okay, but the outer retina was okay, right? So any other
retina. And very intrigued case because we have scotoma, temporal scotoma, and have some atrophy of inner layer, as Gerard mentioned. And what can cause this? Light, trauma, the guy that's operate in a differentiated touch with the vitrectomy or any other tools in the retina, we don't know. And we don't know if this, they said that not remove the entire limitation membrane that can cause this. But very intrigued because looks like the ellipsoid lines is intact, but we have this little atrophy in ganglionar layer.
Right. So okay. Just I want you guys comment this. That surgery was done in 2021, and that paper was published last year, right? So Rick Spade talked about that central vision with macular ganglion cell loss after posterior segment surgery, right? As Gerardo said, most of the cases were done by epiretinal membrane or micro-hole surgeries. Only one case was related to retinal detachment. So there was he thinks that there is a macular loss, just a focal macular loss of ganglion cell layer, right? And that's the table shows the macular ganglion cell volumes in the patients in an involved eye at the left and the right eye, the fellow eyes. So there's a large difference. So as I said, the surgeries was most of the time, as Gerardo said, with IOM peeling, but this patient and one of the paper was not. So in conclusion, this focal loss of ganglion cells may be related to the visual loss of these patients. And you have to think about it and have to presume this when you see a complaint of a central scotoma, right? And you see so you make the OCTs images and the ganglion cell layer volume measurement to do the diagnosis. So I don't know how frequent is this. So I'm asking you, if you have seen those cases, you share with me. That's my email above, below. And we can publish together similar cases as Richard Spade did last year. Any comments about the paper? And
I have some questions about the paper. In the discussion, what the hypothesis is made for that? It's ischemic. What's the idea? Why that's ganglionar cells atrophy? Why that? It's ischemic saying.
We don't know. Rick Spade doesn't know also. So maybe it's trauma by ILM peeling or hyaloid peeling. That patient had a hyaloid peeling, and or by air, as Gerardo said, the infusion of air, losing the ganglion cells. But it's not sure. There's not an ideal explanation for this. It happens.
I have another possibility that I just remember now. I don't know if Gerard remember at the beginning of the pandemic time, we have a live meeting together, and I present some complications in the vitrectomy. And I present a case that was a high myopic eye with bolus, retina detachment. And when I just get inside the eye, has a tears temporal to the macular. And I presume was the jet stream of the BSS. When I open the BSS with high pressure, they make a hole. And maybe not only the air that is directing for when you make the air-fluid exchange, but also the jet stream of the BSS can touch in that position more strongly and make damage. And maybe that. Remember, Gerard, that case was the Bauschlom meeting.
Yeah.
And
yeah. I mean, there's a lot of stuff that we're putting inside the eye. So the dye, if you're seeing brilliant blue or something like that, the jet stream can also damage the retina. The BSS, as you said, if the retina is very bullous, using the trocar can also damage the retina. So there's a lot of stuff that happens during what we do. It's very hard to pinpoint exactly what could have caused this kind of damage.
It could be because of the gas tamponade, as we know that the gas is having a more buoyancy and it get a configuration of the optic disc, and we ask the patient for the supine position. So the prone position. So actually this we experienced this type of cases, like we had unfortunately consecutive patients who had this type of scotoma after the vitrectomy surgery with the gas, and that time we had the same discussion, and we observed that all the same techniques generally it happens in the patient where we are putting the gas more often, like gas, and the cases were for the ILM peeling and the macular holes, where we observe this phenomena a bit more. So that time we also had the in-group discussions, and we realized somewhere it may be the gas which is causing maybe the cause behind it. Gas tamponade.
That's true. And we are almost approaching the end. Have some questions. Rajiv, you still here?
No, he went to the OR.
Oh yeah, he went to the OR. Some questions that I just saw at the beginning in the question box. They all also respond all, but some question that's very nice to just highlight. One question is, is we should take the less drainage as possible. And the idea now is less is more. If you cannot drainage and let the RPE work, the data has shown us that's the best way for improved vision. When you actively remove the subretinal fluid, we may cause displacement, and maybe we lose some photoreceptors. That's important. The other thing is the PFO, how to use. It's the same principle. Less is more. If you can work without PFO, is better. But sometimes, like Dr. Sentes has shown us in the large retina tears, the giant retina tears, or if you need to do some retinectomy, and sometimes we need to use PFO. We have to avoid this as much as possible, but it's not something that we should not use.
George, just a comment. Rajab has a great work, so many papers about it. It's a very important matter, right? But one problem I see it's that when you change your technique doing surgeries, doesn't matter if you do buccal or pars plana vitrectomy, primary vitrectomy, you may have some redetachments, right?
Yes.
Your improvement tax of reattachment may decline, right? So you have to train again how to do it, how to put less gas inside the eye and the post-op positioning, and so it will be a different surgery, and there's a learning curve about anything you do it different. So so it's I know we have to improve or the vision of the patients, but it has a cost. Probably it's a low
I
cost.
agree with you about these ideas. For example, pneumatic is something that in the 5 years ago I almost not using, and just because we are discussing so much, and I changed my techniques, and I'm using more. I don't have 80% reattachment with pneumatic, but I think I have between 60 to 7%, and a very happy patients. But I just learned that if you fail with your pneumatic, the next surgery, buccal or vitrectomy, it's not be worse than if you just start primarily with the vitrectomy. And I agree that we don't reattach 100% of the retina. I mean, it doesn't matter that's simple case or complex case, but have a chance not reattach. We need to reopen and reoperation. And this reoperation, we need to use all the tools we have in the box, just because we need to reattach this. All we are discussing now is the primarily approach for this retina, and then we are trying to do the best. And the idea to discuss quality of vision is something very important. We are changed our mindset. It's completely different from the old time. That's okay, if you reattach the retina, everything is done, everything's perfect, it's okay. Now we are discussing, what's the best way to reattach this retina and get the best vision? I agree, we are in the learn curve, we have a lot to learn, but we are changed our mindset. We are just thinking the different way, but vitrectomy is still a very good technique. We are doing this many times. We attach so many retina with vitrectomy, and nowadays we have so many good improvements in the equipment, the technique, and that is much more safe than the old times. But I agree with you. We are just in the learn curve, have a lot to learn. This is gonna cost a lot, but I think the mindset change is really something that's real matters for everyone. I think we have the audience here that's sometimes more than 60 persons, and I think these people are gonna think differently tomorrow when we'll go for the OR and try to fix the retina. This is the idea, to start to rethink the retina approach, and then I think we are doing good. I think I have to thank all of you because I really learned a lot. It was great to be here, and I think we need now the boss. Mohammed, it's all your. I think you like the session. We are smiling. I think you like this conversation and new ideas. No, it's mute.
Yeah, as usual, forgetting. Thank you very much, George. Thanks everyone here, Dr. Gerard, Dr. Sergio, Siti, and Dr. Mohit, and Dr. Rajiv. It was really an impressive and great discussions. Thanks for your times, and we hope to see you again. These are the things that we need actually, to share the experience from different part and different aspect, so everyone can learn from others about how he is managing and how he can manage. And everyone, there is no one can say I know everything, so we are learning from each others. At the end, thank you very much. I know most of you, sorry Gerardo, we are keeping you, I know you have a clinic, so thank you very much. We will close by this, and we hope to see you inshallah soon. And welcome also to the 5th MIOM conference. It will be in Dubai in 19 to 21 of October. We are waiting to see you all there, inshallah, hopefully. Thank you very much, and good night. Bye-bye.
Thank you very much for the invitation.
Bye-bye. Thank you so much.
Thank you so much.
Thank you, Rajiv.